Welcome to the Adrenaline or Epinephrine Pharmacology Masterclass. This video is targeted at healthcare professionals preparing for exams like NORCET, RRB, and AIIMS. Let's begin with our first question. Adrenaline is a non-selective endogenous catecholamine. Which combination of adrenergic receptors does it directly agonize to produce its life-saving physiological effects? The correct answer is C, ALPHA1, beta-1, and beta-2. Epinephrine is a powerful, non-selective sympathomimetic amine that acts on these receptors, making it the ultimate rescue drug in cardiopulmonary emergencies. Next question. A patient develops severe anaphylactic shock. What is the universally recommended concentration and route for the initial dose of adrenaline in adult anaphylaxis? The answer is B, 1 to 1,000 via intramuscular injection. The standard of care for acute anaphylaxis is epinephrine 1 to 1,000, administered intramuscularly in the thigh, which provides rapid and reliable absorption. A nurse is educating a patient with a severe allergy on how to use an EpiPen autoinjector. Which anatomical site should the nurse instruct the patient to inject the medication? The correct site is C, the anterolateral aspect of the thigh or the vastus lateralis muscle. IM injection here yields significantly faster and higher peak plasma concentrations of epinephrine. During a code blue for a patient in ventricular fibrillation, what is the correct dosage, concentration, and interval for adult cardiac arrest according to ACLS protocol? The answer is A, 1 milligram of 1 to 10,000 IV every 3 to 5 minutes. The crucial detail is the dilute 1 to 10,000 concentration. Giving 1 to 1,000 IV push inadvertently can cause lethal myocardial ischemia if the patient has a pulse. According to the current AHAACLS algorithm for VFib or pulseless VTAC, when is the first dose of epinephrine administered? The correct answer is C, after the second defibrillation shock. For non-shockable rhythms, epinephrine is given as early as possible. However, for a shockable rhythm, high-quality CPR and early defibrillation are the absolute priorities. Epinephrine is often combined with local anesthetics like lignocaine. What is the primary pharmacological rationale for adding epinephrine? The answer is B, to cause localized vasoconstriction, prolonging the anesthetic effect. Adrenaline stimulates alpha-1 receptors, decreasing local blood flow and slowing systemic absorption, which prolongs anesthesia and reduces systemic toxicity. Lignocaine with adrenaline is strictly contraindicated for use in which specific anatomical areas? The answer is C, areas supplied by end arteries, such as the fingers, toes, nose, penis, and pinna. Prolonged vasoconstriction in these areas can completely cut off blood supply, leading to severe tissue ischemia and necrosis. During a severe stress response, or following epinephrine administration, a patient's blood glucose levels typically rise. By what primary mechanism does adrenaline induce hyperglycemia? The correct answer is B, promoting hepatic glycogenolysis and gluconeogenesis. Epinephrine acts on beta-2 and alpha-1 receptors in the liver, breaking down glycogen and forming new glucose for the body's, quote, fight-or-flight response. Epinephrine is a highly potent bronchodilator. This life-saving respiratory effect in severe asthma attacks or anaphylaxis is achieved through the agonism of which specific receptor? The answer is B, beta-2 adrenergic receptors. Stimulating these receptors increases cyclic AMP, which leads to smooth muscle relaxation and immediate, powerful bronchodilation. If a patient receives a continuous high-dose infusion of epinephrine in the ICU, the nurse must closely monitor the patient's basic metabolic panel for which expected electrolyte abnormality? The correct answer is C, hypokalemia. Epinephrine stimulates the beta-2 receptors, which drives potassium into the cells, potentially leading to transient but significant hypokalemia. When a moderate IV dose of epinephrine is administered, the blood pressure typically rises initially, but then falls slightly below baseline before returning to normal. This phenomenon is known clinically as, the answer is D, biphasic epinephrine response, which is related to Dale's phenomenon. A patient on a non-selective beta blocker is inadvertently given a large dose of epinephrine. What dangerous physiological reaction is most likely to occur? The answer is B, severe hypertension and reflex bradycardia. Since the beta-2 effects are blocked, the powerful ALPHA1 vasoconstriction is unopposed, leading to a hypertensive crisis. An IV line infusing adrenaline infiltrates, causing drug extravasation. The nurse must promptly obtain an order to inject which antidote into the affected area. The correct antidote is B, phentolamine. Phentolamine is an alpha-adrenergic blocker that reverses the intense, localized vasoconstriction caused by extravasated epinephrine. During a pediatric resuscitation code, what is the correct standard pediatric dosing formula for IV or IO epinephrine in cardiac arrest? The answer is B, 0.01 milligrams per kilogram of 1 to 10,000 concentration. Note the importance of the dilute 1 to 10,000 concentration for IV or IO use. Racemic epinephrine, administered via nebulizer, is a staple in pediatric emergency medicine. It is the primary pharmacological treatment for which acute pediatric respiratory condition? The answer is B, croup, or laryngotracheobronchitis. Racemic epinephrine's alpha-adrenergic effects reduce subglottic edema. Epinephrine is naturally produced within the human body. Which specific anatomical structure synthesizes and secretes endogenous epinephrine directly into the bloodstream? The correct answer is C, the adrenal medulla. This part of the adrenal gland is primarily responsible for synthesizing and secreting epinephrine and norepinephrine. Epinephrine is rapidly degraded by MAO and COMT enzymes. What is the final metabolic byproduct excreted in the urine? The answer is A, vanillyl-mandelic acid, or VMA. Testing for VMA in urine is used to diagnose catecholamine-secreting tumors like pheochromocytoma. In anaphylactic shock, adrenaline completely reverses the collapse caused by massive histamine release. Pharmacologically, what is the relationship between epinephrine and histamine? The correct answer is C. Epinephrine is a physiological antagonist of histamine. While they act on different receptors, their resulting effects on the body are opposite and counteract each other. An ICU patient is receiving an epinephrine infusion. The nurse knows that if the infusion is abruptly stopped, hemodynamics will change very rapidly because the biological half-life of IV epinephrine is approximately. The answer is A, 1 to 2 minutes. Epinephrine is one of the fastest-acting drugs, allowing for rapid titration and quick cessation of effects when the infusion is stopped. During obstetric emergencies, epinephrine must be used with extreme caution. Aside from causing maternal hypertension, what is the primary adverse effect of epinephrine on the pregnant uterus and fetus? The rationale is B. It relaxes the uterus but severely decreases placental blood flow. Epinephrine's effects can cause fetal hypoxia and acidosis, severely stressing the fetus. In the treatment of asystole or pulseless electrical activity, defibrillation is useless. Instead, epinephrine is given early. What is the primary rationale for this intervention? The correct answer is B, to increase aortic diastolic pressure, driving coronary perfusion. This improves the chances of return of spontaneous circulation. A patient in anaphylactic shock has severe coronary artery disease. What is the absolute contraindication for administering intramuscular epinephrine in this scenario? The answer is D. There is no absolute contraindication in life-threatening anaphylaxis. In an emergency, the risk of untreated anaphylaxis far outweighs the risk of myocardial ischemia.